Welcome to the Ultimate Dental Podcast, the place where you can learn how to create a dental practice and a business life that you love. Listen in with Dr. David Moffet as he interviews successful entrepreneurs and successful business people and successful dentists as they share their business successes, their stories, and their breakthrough ideas, sharing pearls of wisdom that you can take back to your practice and implement immediately so that you can have that great practice with more patients, higher profits, and less stress. This is the podcast where great dental practices meet with successful business processes. Thanks for tuning in to the Ultimate Dental Podcast, the podcast where thought leaders, industry experts, and thriving practice owners reveal their very best tips, tools, and strategies that will help you grow your dental practice faster. Now, here's your host, Dr. David Moffet.
Hi everybody, it's Dr. David Moffet here. It is Friday morning, coming up to 9:30 in Burrowang, New South Wales. Welcome to the latest episode of the Ultimate Dental Podcast. It gives me great pleasure to introduce to the podcast studio Sheldon Krancher, who is in Houston in Texas, where it's coming up to 4:30 Thursday afternoon. Sheldon, welcome to the podcast studio. Thanks for joining me.
Thank you for having me. It's good to be here.
Yeah, Sheldon. Now, you and I met officially, I think, in about September last year, and we've been working on something that you've been working on for a long time, which is helping dentists to, get better results, more consistent results with aligner therapy. Would that be a good summation of what you're up to and what you've been working on for, I think, the last 10 or 15 years?
Yeah, that's exactly right, David. It's kind of an interesting story. I'll just kind of jump right in. I remember as a fairly young Invisalign territory manager, I remember my very first call. In fact, I even remember calling my manager because, you have home study, and I called my manager, Jim Zarzor, who we're really close friends still. And I remember calling him on the phone and saying, "Hey, Jim, can I, I think I have this stuff down pretty good. Can I go out and start making calls?" He's like, "Yeah, all right, go ahead." So I go to this really low submitting practice up the road from my place. And I walked in and two things happened. One was a set of models in my face saying, "Is this a good Invisalign case?" Of course, my answer to that was yes. And then he walked me over to a screen with a ClinCheck on it. And I think it was an Express 10 that was on its fourth refinement. And he was asking me why. And that was literally my first experience ever with the problem that we've now solved over 600,000 times over, 15 plus years later. And it was from that one experience. Of course, I saw that experience, over and over and over again, thousands of times in the US, later in the UK and Europe with Align. And I knew there was a better way to do it. So that's kind of a little bit of the backstory there.
Well, I think having been a dentist for 35 years, that was one of the issues that I found with aligner therapy was it was a lottery. Let's send it off. Let's see what they say. And once they say that, and you get your first lot of aligners, and it doesn't give you the result you want, your refinement can be more aligners than the original course.
Yeah,
With
that's
more
the
attachments.
worst.
And I'm going, what?
Yeah. That particular scenario, sadly, is not an uncommon scenario where the refinement is more stages and more everything than the initial phase. And of course, that can be very confusing for the treating doctor, of course, very frustrating for the doctor as well as for the patient. So yeah, there's a whole host of scenarios. And yeah, I think one of the things you kind of point out is makes me think about the fact that general dentists mostly, and certainly as it relates to orthodontics, they don't know what they don't know. And so there's a sort of dependency on the aligner lab. And as it turns out, the aligner lab, the one thing they're not doing is making a clinical diagnosis. And so therein lies a bit of the problem and the challenge. And that's a sort of, I call it the diagnosis gap. And that's the gap that we fill.
Well, I think a lot of general dentists, when they start doing aligner therapy, believe that they're getting a diagnosis and and a treatment plan. But it's not really, when things don't go as they're expected, the dentist is on his or her own, with whatever the authorities are in terms of, well, why, doctor, are you doing this if you haven't got the skills? And they have got the skills. It's not that difficult to do aligner therapy. It's all force and vectors, really. They learnt that at high school. It's just knowing how to get the best result and the quickest, and also, in the shortest time, but also something that's going to be stable as well, Sheldon, isn't it?
Yeah, no, you're exactly right. And sadly, there has been a very strong perception, I'll say created, let's say, by the broader aligner orthodontic lab community, that there is some level of clinical diagnosis. I mean, they call it, there's of course an online prescription form, there's clinical support, there's, the ClinCheck. So, I know I'm speaking specifically to Invisalign, but across the board, the perception has been created until the time that, as you correctly point out, David, when the results aren't there, then it's on the doc. It's on the doc because they're the ones responsible for making the clinical diagnosis. But if they haven't had the proper training, and so it's a bit of a vicious circle there. And that's what we've been addressing. Interestingly, 15 years later, in fact, I had a conversation with a very nice doctor out of Florida, Dr. Sonia Reddy. Very nice. She's an airway doctor. And she's like, I've never heard of your company. And I didn't know that, a solution like that existed. So here we are 15 years later. And so thank you for supporting the effort here on really kind of getting it out there, because I think that's still where we are. But of course, we're starting to really gain some significant traction. So this is a good point forward.
Well, aligners, I'm fortunate enough to have practiced in the dental field before aligners were invented, and then when they came along, and they have grown in leaps and bounds in what they can do, such that there are now orthodontists who only do aligner therapy. So that it is a credible way of treating patients without them having to have a mouthful of braces and physical hardware. I was an adult and had adult orthodontics with braces. My wife, as well as an adult, had adult orthodontics with braces. My daughter had physical braces, but my son had Invisalign. And his results are probably the best of all of us.
Yeah,
I think
yeah.
it was quite interesting. It's amazing that technology is now very much mainstream, but yet if something goes wrong, there's a punishment or perceived punishment coming for those who have, I guess, relied on the assistance being valid.
Yeah. I think there are three areas in which there are potential challenges, and I like to kind of classify them as a sort of clinical barrier, a technical barrier, and then a communication barrier. And so I think with general dentists, again, and in certain markets, certainly here in the US, there's almost zero orthodontic training in dental school. And so that clinical experience, that clinical expertise, that ability to accurately diagnose an orthodontic case, that's a common challenge, one that we obviously support and help overcome. Then there's a technical challenge, because at the end of the day, we're talking about a piece of software. And in my experience, having been in healthcare for 35 years, and this hasn't changed, that software and doctors don't really get along that well. I think there is a generation now that's maybe less true. And then the third piece is that communication, where the treating doctors are attempting to have a clinical conversation with, now what I say is, maybe a technician on the other side of that screen. There was a time when they were all certified, trained technicians. Unfortunately, that's not true anymore. I mean, we've seen a significant decline in the quality of those first digital treatment plan setups across the board, not singling anyone out. But those are the three barriers. So any one or all of those can really change the whole entire dynamic in terms of what you're actually getting, what you're approving, what you're putting in the patient's mouth, the potential impact, refinements, multiple refinements, which of course has a significant impact on doctor and patient experience, profitability. I mean, I can go on and on. We could talk about any or all of these things as it goes. It's not just an isolated, it's not just one reason why things, and here's the crazy thing, as advanced as things are and how much things have evolved technologically, fundamentally, we still find those three primary barriers and nothing's changed in that regard. So it's really interesting, 25 years later, we're still having the same exact conversations about, premature posterior contacts, or premature anterior contacts and posterior open bite. It's like, are we still really talking about that 25 years later? It's incredible to me. So it's all good fun though.
What are the major problems then that aligner therapy gives you? You just mentioned one then. Are there any others? How are you going about to help dentists doing aligner therapy
Yeah.
to avoid these continuing same problems happening?
Yeah, I think the one that's most important that I'd like to address. Thank you for the question. It's a great question. The one that's most concerning to me that we see pretty regularly or skeletal discrepancies, dental or skeletal class 3 cases that are being submitted. They're being referred over to us for the diagnosis and what we call treatment plan optimization. And pretty much across the entire aligner spectrum, those cases would go to manufacturing. And those cases shouldn't be treated in aligner therapy. And we're at liberty to tell them that. The aligner manufacturer typically isn't, because that would technically constitute as a clinical diagnosis in some form. And the regulatory bodies, FDA, CE mark, or otherwise, restrict aligner manufacturers because they have a class 2 medical device from making a clinical diagnosis. That's the other part of this story here. And so those are the ones that we see that we're especially concerned about. And then, of course, the doctors, they don't want to be told that they can't treat the patient with aligners or that they shouldn't treat them because they're going to get a compromised outcome. I would say that's the one that really comes to mind as most concerning. And we see it a lot. And again, that's part of the value that we bring, not only obviously in a case that is suitable for aligner therapy. We're going to give them a thorough diagnosis. We're going to optimize the plan for the most stable, aesthetic, and predictable result. How we measure that, how we measure success in general, is our refinement rate. And our rate of refinement is consistently less than 25%. But I would say that's the one that stands out. There are others. Obviously, there's a whole range of clinical conditions and case types. But as you mentioned earlier, we're able to more successfully treat more conditions, more clinical conditions, more case types successfully than ever before. And we obviously help facilitate that with the doctor.
I find that hard to believe that doctors are actually submitting class 3 skeletal cases to Invisalign and not realizing that it's a bone size discrepancy, bone placement discrepancy. What do they think the Invisalign, their upper anteriors are going to be at 45 degrees if they get them into a class 1 relationship without fixing the bone, the jaw relationships first? Do they have unreasonable expectations, or do they have unsuitable education?
Yeah, I think a few things come to mind. One is, generally speaking, they're looking for some sort of aesthetic result. They might be doing something in combination with something restoratively. Maybe the patient has declined surgery, for example, not uncommon. A lot of people decline a surgical solution. But I think there is some expectation that an aligner system or brand can do some sort of magic. And then again, the perception that there's some sort of clinical diagnosis going on when in fact there isn't. So I think it's a combination of things. But it's an interesting scenario. We've picked up the pieces on countless refinements, David. You can only imagine the stuff we've seen at north of 600,000 cases globally. We've pretty much seen it all from most regions in the world.
It's fascinating. I know in my practice, Sheldon, I did an examination, radiographs, cone beam. And I told the guy, I said, "You've got a class 3. I said, "I can't treat it with Invisalign." And he left my office, quite upset apparently, and left me a 1-star review. And I thought, geez, you just told me that you're unhappy and I'll give you your money back. But I can't fix what I can't fix with the tools that I have. I know that Invisalign won't do this, that you do need surgery. And
he should have given you a 5-star review for telling him the truth.
Yeah. My big fear is that somewhere out there, some guy has actually tried to do that for him. So
unfortunately,
but they're fairly obvious. Class 3s are fairly obvious, and any form of orthodontic education for a doctor should know. There are some things that class 3, you can't even fix class 3s with fixed appliances half the time.
Yeah.
It is
Yeah.
a surgical answer. Yeah, it's crazy. So how do you go about, what's your secret sauce for probably asking too much. What's your secret sauce for having such a significantly lower refinement rate? It's
Sure.
obviously it's taking the care right from the start. Is it just having the right people doing people with the education, people with the history, people with the right knowledge, so that the dentists do get the results, the patients do get the results, and that those clients live happily ever after for the dentist, and the dentist as clients of your company as well?
Yeah, no, it's a good question, David. I think the short answer is proper diagnosis from the
Mm.
outset. We know that all good results are a function of proper diagnosis, and it's not just the proper diagnosis alone. It's also the proper execution, or again, what we call optimization of the digital plan. And yeah, we're fortunate to have the best of the best. Of course, I spent almost 10 years at Align Technology. And so we started with former Align Technology clinicians. So we have an orthodontist led and trained clinical team. So my goal in the beginning and my vision was that we had to have a clinically trained team, not a team of amazing technicians, which we have some amazing technicians as well, working mostly with some of our labs, full service lab. Maybe we can talk about that later. But essentially, we have the best of the best. There's no question about it. We have some of the original employees from Align Technology in Costa Rica, like the first 5 or 10 or whatever it was. And so we're very fortunate. They've literally seen everything. They've seen the full evolution. And so that's part of what we're able to leverage. And I'll also say, and many have tried, it's not just a simple matter of, oh, we'll just hire someone from Costa Rica, or we'll just hire a few people from Costa Rica. Good luck with that. It's not as easy as it looks. We've really built from the ground up, and we have a very, very solid infrastructure, a clinical team. We have the ability to scale. We scaled up for Aspen back in 2020 when I got the phone call from them, and we ramped up to 3,000 cases inside of like 8 weeks. They were on a 3,000 case backlog. So we've been able to really establish ourselves well. And then of course there's the fact that experience matters. And when you're at, case 200,000 or 250,000, I mean, even the best and most skilled orthodontists that treat, in some cases, as you mentioned earlier, liner only practices. It's still kind of a novel thing. It's still kind of a new thing. They've maybe treated, I don't know, and you probably know some numbers, 3,000, 4,000, 5,000, maybe 10,000, like off the charts. Well, we're talking 600,000 aligner cases, and not just from one demographic or one market, globally. And as I said earlier, there's nothing we haven't seen. And so we bring that, and by the way, across every aligner manufacturer, almost every aligner treatment planning software. So we bring that experience to every single case, to every single doctor and every single patient. And it's consistent with what we believe as an organization. We believe that there's a patient behind every digital treatment plan. And that really is our compass and our guide in terms of what we do.
Sheldon, let me see if I can get this right about the process that goes on for dentists submitting cases. What they normally do is they submit a case to their aligner company, and the aligner company comes back with a recommended course of treatment, which the dentist then goes and accepts. Now, what your company does is that your company, now when the dentist gets that course of treatment presented to them, your company then has somebody look at that course of treatment and do modifications or optimizations to that treatment plan, so that the patient and the dentist then get what is usually a shorter course of aligners that's going to give a more stable, more predictable result, and also significantly less chance of needing one or more refinements as well following that initial course. Is that a good summation of how your company works?
It is, yeah. And I'll just add that indeed the treating doctor will take all of the patient records. Those patient records will usually be uploaded to the aligner manufacturer doctor site. What's interesting is that I think it was back in 2009, 2010, one of the major aligner brands stopped requiring radiographs, which kind of lends itself to this whole story about clearly the aligner manufacturer or lab is not performing any sort of clinical diagnosis. There's no clinical diagnosis that's going on. And sadly, a lot of times what we've seen, and heard some different numbers, but more than 50% of those first digital treatment plans, and this is true among the general dentist population, is approved. So they will approve that first digital treatment plan recommendation, I think is the word you used. And then, of course, it goes to manufacturing. And then, of course, about 95+% of those cases will require at least one refinement. Upwards to 63+% will require a second refinement. And again, it goes back to the initial point I made. How do we do it? And does our success lie? It lies in proper diagnosis from the beginning, of course, in addition to that optimization and really optimizing the plan. In fact, a lot of what we do, a lot of what our clinical team does is they will eliminate unnecessary movements because again, these software program defaults will put all kinds of stuff and movements and, why are we moving that tooth and why are we moving it at all or in that way? And of course, removing unnecessary attachments. Again, a lot of the attachments are program defaults. So we're doing a lot of undoing of what it's being initially proposed. And in most instances, I think you mentioned this as well, and you're correct that the total treatment time can be anywhere from 10 to 20% in terms of the number of stages. So anywhere from 10 to 20%, sometimes more, less stages than what is being initially proposed. So indeed, shorter treatment time, more stable, more predictable. And I like to say that we eliminate unnecessary refinements. We're not saying we eliminate all refinements. I think some refinements are necessary, especially if, you come up slightly short of what your treatment goals are, or the patient isn't happy, or maybe the treatment plan changed. Now you're doing veneers, for example. So we need to, in the revision or refinement phase, we can create some additional space for the veneers. And so that's kind of how the process goes. Now, because our refinement rate is so low, and again, less than 25% rate of refinement, we include a refinement in our fee because we're confident, generally, depending on the price point, but generally speaking, any doctor who's paying list price, for example, will always include a refinement in that treatment plan, knowing that 25% or less of the time it'll even be required.
It's interesting. One thing that really tipped me over the edge with one of the companies was that I think the case required 10 or 12 aligners, and then the refinement required 16 more aligners. And I thought, if 10 or 12 gets us 90% of the way there, why do I need 16 to get that last? And I think it may have been that case or another where I was just trying to straighten one or two anteriors a little bit better. The case came back with attachments on premolars. And I'm going, what are we doing back there? This isn't the patient's concern. The other thing which I did once, Sheldon, was I took the impressions back then with all the attachments still on the teeth, and they virtually removed them all and gave me a new set. And I'm going, well, would they have no use at all? These are the frustrations doctors have, and I only say that as an observation. Was that part of the norm? Was I experiencing that as part of normal operating? Yeah, we're talking.
I think
12, 13 years ago.
I think that was quite common back then, and of course a lot has changed. And again, not much, really, a whole lot. I mentioned that earlier. I mean, in 25 years, we're still talking about a lot of the same things. Of course, what has changed is the technology, certain features of the software. Of course, scanning technology gets introduced and monitoring technology platforms as well. So in that sense, there's been a lot of change, kind of peripheral to the aligner solution itself. I think in terms of the treatment and the treatment outcomes and the challenges that come along with treating patients with aligner orthodontics, that's kind of all the same. And it really hasn't changed a whole lot, which again is, on one hand, is kind of, you scratch your head. But on the other hand, I think it's a testament to how needed and how valuable a service like ours is to bridge that gap, to be that voice of reason, to be that extra set of eyes, to be that conscience, that partner, that support for the treating doctor, hopefully knowing that they're not going to get that level of support, or after a certain period of time, they figure out they're not getting the level of support that they need, certainly not from a clinical diagnosis perspective. And again, a lot of these companies have positioned and postured in such a way to enhance the perception that there's some sort of something clinical going on, when there's still that fine line. And if something goes wrong, you're the treating doctor, you're responsible for the diagnosis, we're not.
Yeah, it's tough when that happens, as a treating doctor. You mentioned, I think you said Dr. Reddy didn't even know that your company and its service was around. It's kind of given me a twofold question. Are there other people doing what you're doing? That should be just a yes or no, or not many sort of answer. There's that one. But the second one is, do the aligner companies know that you exist? And are they able to, this is my clandestine thoughts, evil thoughts, are they able to say, obviously your doctors aren't declaring themselves as saying, I'm getting a professional to give me a proper diagnosis because the company's not there. Are they able to gather that sort of information? This looks like it's being done by Sheldon's company. And then are they then able to filter that and create their own treatment plan?
Yeah.
Or do they not care?
Yeah. So it's a really interesting question. Indeed, the first question is a shorter answer for sure. Yeah, there are other companies that are doing something similar to what we are doing. Of course, you have plenty of orthodontists who are, have their own, group of general dentists. The difference, again, of course, is, a couple thousand or 10,000 cases with experience with maybe one brand or two brands versus 600,000. Again, I think you get the idea there. But in terms of the companies, so we are strategically aligned and even fully integrated with some of the major aligner brands already. And my vision has been for a very long time that we will be fully integrated with all the major aligner brands. We're fully integrated with other, what I like to call aligner lab brands that have taken on, because that's a whole other emerging segment that's really, really interesting, that has the potential to rival even some of the big box brands, and even collectively you have these network of labs, these dental labs that now have access to all the stuff, whether it's 3D printing materials, software platforms, companies like ours, for example, we plug in. So they have access to the information. How or whether or not they're actually able to use it, or to your point, do they even care? I think what they are maybe conscious of is compliance with that regulatory body, again, FDA, CE mark or otherwise, because it's pretty clearly laid out and delineated in terms of, they don't want to cross that line, that line of clinical diagnosis. I mean, they'll get really close in terms of creating the perception for their doctors. I think we established that. But crossing that line and actually getting into that realm of clinical diagnosis, I think that potentially poses a liability, a legal liability. It's not something they're interested in.
All right. So because you do have orthodontists advising, that allows you to give an expert opinion for the optimization before the course of the original course of aligners comes. And so now I see the differentiation between the perception of what the general dentist thinks he's getting from one of the big companies it's really just a mechanic, as opposed to a doctor doing a mechanic, or even just a machine, really, isn't it?
I mean, well, it's a piece of software at the end of the day. And then the other point that's worth mentioning, actually 2 points. One is we're not a regulated entity. We don't have a class 2. We don't manufacture a class 2 medical device. We're not an FDA regulated entity. We're a clinical consulting company. That's what we do. That's all that we do. And so, of course, the treating doctor assumes responsibility for the patient. They're the ones, that are actually treating the patient. But the other point that I want to make that's important is in terms of just having an orthodontist quote, because I hear this all the time from labs, dental labs in different parts of the world. They're moving into providing aligners because their doctors are asking for them. And we approach them and, we tell them about our service, and they say, no, we have an orthodontist. I said, okay, cool. let me know how that works out for you. And then, 3 months later, 6 months later, they're calling us because the sad truth is that not all orthodontists are created equal. Number one. Number
Mhm.
two, not all orthodontists in every part of the world have any experience with aligner therapy, but they have an orthodontist, which I get it. I mean, I'm sure they're incredible orthodontists. I'm sure they're incredible clinicians, but if they've never planned or treated an aligner case, well, that's not going to work out very well if their responsibility is to see to it, right? That these cases are planned properly and executed properly. And so that's, I think, a big misperception for dental labs, especially that they somehow have this false sense of security. And for that matter, even here in the U.S., and I don't know how different it is in Australia, but dental orthodontic residents. In fact, last year I was at the AAO in Philadelphia. I share this story a lot because it makes the point. Ran into a group of 5 or 6 really bubbly second year orthodontic residents. And so I stopped them and I said, how many aligner cases have you all treated? Between the 5 or 6 of them, I think the answer was 4 in 2 years of orthodontic residency in 2025, David. I have to tell you, I take issue with that. I really, truly do. I have a problem with that. I have a problem with the fact that that orthodontic residencies aren't equipping their orthodontic residents to be trained and proficient with the aligner therapy going into practice. I think that it seems criminal to me. Honestly, I would take it a step further. I think it's a shame that fourth year dental students, or whether that be AEGD residents or GPR residents, after the fourth year of dental school, that they're not introduced and they're not working with aligner orthodontics. I think it's a real shame. I think it's an opportunity for us to do
It's
better.
definitely an opportunity. I didn't realize that the education side of orthodontics was for
Yeah,
undergraduates, for orthodontics as a postgraduate degree is so far behind mainstream. A general dentist is probably doing more aligner therapy than somebody
in
training
some
to be an
cases. Yeah, yeah, yeah. That's probably another podcast.
well, so I did hear of something similar down here where a general dentist was studying orthodontics in a different state, and he came back to he was working for one of the corporates in another state, and he said if they found out that he was working in a corporate office while studying orthodontics, he said I would not get any work at all in that other state as an orthodontist because of this subculture,
Yeah, it's a
anti-corporates.
rift, isn't it?
And the manager of that corporate office was saying, we haven't got an orthodontist, and you're being educated as one, and you've worked for us as a general dentist. We want you to just do some work, and so the public's suffering in that area. It's
Yeah,
quite weird,
yeah.
but that's the politics.
Unfortunate.
Back to my undergraduate years in orthodontics study, as going through dental school, I just learned how to write a referral. That was it.
Right.
And I think it's the same in some oral surgery schools too.
Yeah, yeah. And again, in 25 years, that hasn't changed,
It's
unfortunately.
no, it's weird. It seems like the world is your oyster then with all this opportunity, Sheldon.
It is. It very much is. And we're very fortunate to have a global footprint. As you know, we've had some strong relationships in Australia for quite some time with Jeffrey Hall and OrthoEd. And that's been fantastic. Again, through our relationships, our global strategic partnerships with some of the aligner brands, that's been amazing, if for no other reason than the fact that it's put us in when we're operating in over 51 countries now. And so that will continue as we go down this path and we forge this path of being fully integrated. We will be the gold standard across the aligner industry. Eventually, I envision eventually every aligner brand will have some sort of third party treatment planning provider that are solely responsible for diagnostics, that they will bridge that gap between aligner lab, aligner manufacturer, and treating doctor. I think you know this as well, David. There's an increasing interest and tendency for even orthodontists who, again, are either very skilled in orthodontics and or specifically in aligner therapy, where they just don't feel like spending all the time going back and forth with a technician, and they want to offload that. They want to outsource that to a company like ours. We're seeing an interesting trend, that suggests that there's an increased interest and number of orthodontists who are also taking on a service like ours.
Fantastic. Fantastic.
Yeah.
The orthodontist who did, I think we were mentioning before we, we hit the record button, that the orthodontist who did my wife's braces and my braces as adults and my daughter's braces, he's just sold into a group practice to facilitate his retirement. But he was the one I was telling you about who had turned his practice from fixed appliances to 100% aligners. And so he'd be the kind of person who would definitely be a knowledgeable asset to a service like yours in helping general dentists
Absolutely.
get their aligner cases better, to better diagnose, shorter treatments, and less options in terms of having to have so many refinements.
Indeed.
That's the annoying part. Sheldon, are there some teeth that just won't move with aligner therapy? The one that sticks in my brain is an upper lateral that it just
Yeah.
couldn't budge and did need composite in the end. Has that changed?
No, it hasn't. It's funny. So when you first mentioned, I'm thinking, wait, is he talking about ankylose or an implant? Yeah, neither of those will move very well. But you mentioned laterals. Yeah, laterals yeah, they're just difficult to get a hold of. That's
Yes.
really, I call it I have a name for it. I call it the watermelon seed principle. It's when you
Okay.
try to pick up a watermelon seed and you can't, you just keep slipping out of your hands. So I think that's the principle. Obviously, there's an emphasis on making sure that, and you know this from experience, to move teeth it requires time, pressure, and space. And so with the laterals, you want to make sure that there is absolutely zero contact, mesial and distal contacts. There are other techniques. I think we call it the horseshoe technique, where you can, put a button on either side and extrude that lateral. So there are a lot of fun techniques, but yeah, it's still difficult. That hasn't changed, but I think there are some interesting proven techniques to manage. Yeah, it's a good one.
Yeah. Well, Sheldon, it's been great chatting with you. In the notes after this, I'm going to put how people can get in touch with you, especially those dentists in Australia that I've been working with and with Dr. Jeffrey Hall in terms of helping them to optimize their treatment plans and shorten their their courses and shorten and reduce the number of refinements as well. It's an exciting time because I guess it was tough in those early days when aligners came in. There was not many people really could see that they were going to be as good as fixed appliances, but now they certainly are.
Yeah. Yeah. No. And as you mentioned, we've had a fantastic partnership with Jeff. I think we're going into our 6th or 7th year now. And I think any relationship that's lasted that long is a good one. It's been a real pleasure working with Jeffrey Hall as our regional partner there in Australia. He does a great job and very, very innovative. You know him better than I do, but gosh, he's a real trailblazer. I think he brought aligners to Australia and has been doing them ever since. Fantastic.
Yeah, no, it's exciting working with him. So I'm looking forward to the future of that and working with you
Yeah.
along in this as
Likewise.
well. Sheldon,
Yeah.
thanks very much for your time today. It's been great having you as a guest on the Ultimate Dental Podcast. I've really enjoyed it. You're coming
Thank you
down to
for,
Australia. You come down here quite often,
I
though,
am.
don't you?
Well, often since last year, I think I made it down there twice, which was pretty amazing. Australia was always a bucket place destination for me, so I finally made it down and twice in 1 year. So yeah, I'll be back in April of 2026 for a lecture with Dr. Jeffrey Hall and then Ortho Ed. So I'm really, really excited about that and bringing, I think, a really important message to the masses about malocclusion as a disease, and how to optimize patient education and really informing them of clinical consequences of delayed treatment that, in my experience, is all but absent in those conversations. So really kind of bringing a little bit of a different approach and to talking to patients about aligner therapy and a shift in mindset. So
Excellent.
I'm excited about that. Yeah.
Excellent. Well, hope to catch up with you next time you're down here.
Yeah, I look forward to it. And David, thank you for having me, and thank you for the great work you're doing with the podcast. It's fun to watch things and follow the podcast episodes. It's been very helpful.
Excellent.
Appreciate
Thanks,
that.
Sheldon. Thanks for joining me today.
All right. Yeah, thank you, David.
Thank you for tuning in to another inspiring episode of the Ultimate Dental Podcast. We appreciate each and every one of you for being a part of our dental community and joining us each week on this incredible journey. If you found value in today's episode and you don't want to miss out on future episodes packed with expert insights and actionable strategies, here's how you can stay connected with us. Firstly, hit that subscribe button. Whether you're listening on your favorite podcast platform or watching on our website, subscribing ensures you'll never miss an episode. Secondly, share the love. If you know a fellow dentist or colleague who could benefit from the wisdom and knowledge that we share here, please share our podcast with them. Also, please share the podcast on your socials by simply clicking on the social icons wherever you view or listen to this podcast. Together, we can all do our bit to elevate the dental profession. And finally, stay engaged with us. We love hearing from you. Your questions, comments, and feedback fuel our mission to provide the best content for your professional growth, your personal growth, and for your practice growth. Remember, your journey to creating a dental practice and a business life that you love is our mission, and we're excited to be your trusted guide along the way. Thank you for being a part of the Ultimate Dental Podcast. Until next time, keep smiling, keep striving, and keep on tuning in to the Ultimate Dental Podcast.